Jane. I work at Kettering General Hospital as part of the transformation team, but also as a staff governor for Kettering General Hospital. And it's my, I have to say, pleasure, because I have worked with Sarah for a considerable time, and in a previous life, I think when Fiona was a junior doctor at the time at Cransley Hospice, I worked with Fiona. So I'd like to hand over to these two very inspirational ladies that are going to talk to us or with us today about dying matters. Thank you, Sarah. Thank you, Fiona.
Okay, right. Okay, first of all, just want to say thank you very much for this invitation, and we're really looking forward to having a really interactive discussion with you. There are no slides, we're going freestyle. We really want to talk about any matters around death, dying with you, answer your questions. So feel free to put your questions, like Sue said, into the chat or raise your hand and we will do our best to answer them. We're going to talk around the general themes around death and dying, and unfortunately we can't comment on individual situations. So if you do have some individual situations that you would like to talk to me about, my email address is going to go into the chat. Please feel free to email me about any concerns or, like I say, any individual situations you would like to talk to me about, and I will get back to you over the next few days. Okay, so to kick us off, I thought what we'd do first is just talk about why we feel, Fiona and I feel, this is so important that we talk about death and dying. So, Fiona, why is it important?
Well, I think it's important because it's just such a fundamental part of life, isn't it? We talk about so many other things in life that are important, getting married, having babies, everything else. But for some reason, we find it really hard to talk about death and dying. And obviously, people can be dying of an illness that we have got a bit of warning about. We know that they're going to die in so many weeks or months, perhaps. But also there's those sudden, unexpected situations as well that we might find ourselves in, where someone suddenly had a car accident or a heart attack or something that we weren't expecting. And so when none of us ever want to find ourselves in those situations, and it's often going to be a sad and difficult time. So if there's ever an opportunity to talk about some of the important issues before something like that happens, it just makes a very difficult situation just that little bit easier to manage, and helps people know that they might have done the right thing for their loved one, and helps the loved and the person that might be dying get what they would have wanted in that situation as well. And it's such a broad topic as well, so it could be related to what they might want for healthcare decisions, but it also might be down to, where do they want to die? How do they want their funeral to be? Who would they want to look after the pet dog? You know, who would, you know, the financial side of things. It's such a broad topic, and we have a term for that topic, and it's called advanced care planning, and it can cover different aspects. And I think it is just about, if we're able to talk about it when people are well and able to have those conversations, it just empowers people and just makes the situation so much easier. And again, for example, if you found yourself in hospital, I'm not going to lie, the vast majority of healthcare professionals find it a very difficult topic to approach as well. And we perhaps talk a little bit in a minute about why we find it difficult to talk about. But again, if as members of the public you come into hospital and you're able to express, well, actually, mum said this or mum said that, then that's really helpful information for us to know about. So I think that's why I think it's important to talk about it.
And Fiona, you touched on there about professionals find it difficult. And I would have to say, I think this is sort of a common myth that actually all professionals are happy to talk about it. And actually we're not. We do find it very difficult. I still remember being a junior nurse and having a dying patient in a side room with all the family around. And I was so worried and scared, I actually ignored that patient for the whole day, for the whole shift, because I just didn't know what to say to that patient or that family. And going into a room is with all the family there is really quite daunting. So, and I also think, like the medical profession, we think that we're there to cure and get better, and actually the dying process and looking after somebody who's dying is just as important as saving somebody's life. And we must get it right. And the work that Fiona and all our teams, palliative care teams, do, a lot of that is about empowering our staff and giving our staff the confidence as well to look after dying patients and the families. So again, having a what we could term hopefully a good death. But we do find it difficult. Now, put a uniform on me and I'm fine. You can put me in any situation in the hospital with dying people and relatives. I'm absolutely fine with it. Outside of work, I really struggle to write a condolence card. I don't know what to put. I don't know what to say. And I have to Google most of it all the time because I just find it so difficult. So I don't know what the why out of work. I don't know. Again, it's about trying to find the right words. But in work, I'm fine with it. And I think when I was accosted in Costa by Jane and Sue about doing this presentation, we talked about really empowering the public. So like you've said, Fiona, if we can get the public and patients and relatives coming in and confident in asking what could be difficult questions, that will really help the staff as well answer them. So.
No, I totally agree. I just wondered if anyone in the audience is feeling brave enough to either raise their hands or put into the chat about why do we find these conversations difficult? What is it that we find challenging about it? I don't know if we just give people a couple of minutes to think about that. And I think, going back 100, 150 years, 200 years, it was such a commonplace thing to talk about. But gradually over time, I think there's been changes in society that have made it more difficult. And that might be to do with how our family units work now. We're often not living closely with our families. We might be in different countries. So it might be physically difficult to talk about. Hugely. I think there's been so many advances in medicine that there always might be, is there another treatment? Is there another potential cure? And when is the right time? I can see Sue's got her hand up there.
Yeah, thank you. I wonder if some of it is afraid to say the wrong thing.
Yeah.
And therefore then we don't talk about it.
And what is it, Sue, that we're afraid might happen if you don't mind me asking, putting you on the spot a little bit?
Yeah, I think that's a really good, a really good question, Fiona. Will I bring on their premature death there? How about that? Because I've actually asked them. It was only after talking to Sarah. Oh, and by the way, everybody, when Jane and I accosted Sarah, we were very gentle. No animals or humans were harmed in the attempt. Literally that evening, Sarah, I came home and had a small glass of wine in the garden. It was only a small glass. And I actually asked my husband, and we'd never talked about this before. And I actually said to him, if you were, very ill, would you want to be dying in hospital or at home? And I was very surprised by his response. And he said, hospital. I would never have known that.
No.
And then I asked him, why did you say hospital? Because funny enough, after we started the conversation, it just flowed. It just felt so much easier because it was that white elephant in the room that was kind of, put back in its stable. And he said because he didn't want to put, if he was at that point, he didn't want to put the pressure on me as a very small person, 5'1", no real strength to be able to pick up a 17-stone chap and care for him. And he didn't want our 13-year-old and our 26-year-old to also end up being carers. Whereas then he asked me then, what did I want? And I said, I think I'd want to be in a lovely hospice with people massaging my feet, or possibly at home, but I wouldn't want the pressure on the girls. and him at home, which then led me on to thinking, oh gosh, I'm assuming there are hundreds of beds available in hospices, and we know hospices aren't funded. They're you know, out of the NHS pot. They are funded through the generosity of fundraisers. So gosh, I've thrown in a lot there, so maybe you can start to unpick it, please. Yeah. And then we've got some lovely questions coming in. So
right.
And I'll start going through these in the order that they came in. So I'll make notes.
Okay. I think it's quite a common myth that people want to die at home. And what I think Fiona would agree with, what we find is actually the closer that people get to dying on death, actually they're quite happy being in hospital. They feel safe. They've got professionals around them 24/7. They know their family are being looked after. I think when you hear about these surveys that people want to die at home, they're asking healthy people. And actually, yes, I would love to die at home or in my garden with, you know, my dogs around me. But actually, the closer I probably get to dying, actually, I'd want to be somewhere where I've got nurses and doctors around me 24/7. So dying in hospital isn't a bad thing, okay? And actually, lots of people do want to die in hospital. And taking somebody home to die can be really scary for the person. And I'll never forget a relative once. She described it as taking your first newborn home. You've got like this stranger in the living room and you just don't know what to do with them. And I think that really is quite true. You know, often we'll have the bed brought downstairs into a living room. And it can be quite daunting, but then it can be, you know, exactly the opposite and a really positive experience. And I think what I'm trying to get across here is actually it's okay to change your mind. Okay, so at this moment in time, yes, I would like to die in my garden, please, but actually closer to death, I might change my mind and it might be in a hospital or a hospice. Thank you very much. So, but dying in hospital shouldn't be seen as a failure either. So.
No, absolutely. And I think your other point, Sue, was you were talking about actually, if I talk about this, will it make it happen? And interestingly, that comes up quite a lot, because I think naturally when someone's ill, we're very much wanting to protect everybody. We don't want to upset anybody. It's already a really upsetting situation. And I think sometimes people are worried about, if we start to talk about these things, will that make that person give up hope? Will it make them think that, oh, there isn't anything to live for anymore? But you know what? It's the exact opposite usually, because often what we find is that everybody in the room is often thinking the same thing. It's just that nobody knows how to bring up the subject. And often when you start talking about it, you just see the relief and those, you know, those heavy shoulders relax a little bit more, because actually it's kind of like, oh yeah, no, I was worried about that. Oh yeah, I was thinking that too. Or no, fair enough, we haven't got the answers to that, but at least we're all on the same page with that. And if anything, I think, and I keep using this word empower, but I think it gives people some control over a situation where they feel they may be losing control as well. And so it doesn't give up hope. And interestingly, there's been quite a few research projects on that one as well, demonstrating the same thing. So I think we're fearful, but we don't need to be fearful of it, as long as we don't push people into having conversations they really don't want, which as healthcare professionals we would never do. You know, but we give people the permission and facilitate the opportunity for them to have those conversations.
I think there's certainly a difference, and Fiona will, I'm sure, back me up on this, when we meet a family who have talked about dying to compare to the family that haven't talked about dying, and the anxiety around that family who haven't talked to their loved one about their wishes and their preference is very different to that family who is sat around a bed, who have talked about it. They know what mum wants, they know what she wants to wear at her funeral and the song she wants played at the funeral. It's very different, and it, like I say, it's a lot calmer compared to that family who's quite in turmoil from not knowing what mum wanted.
Yeah, so much to think about, but actually not thinking about it makes it even more painful. Some of the conversations in the chat, so some are questions and some are conversation starters. So our first one is, I've had the most difficult conversation with a dear friend as recently as last week. about her wishes after she passes. I was so nervous. So that's one of the first comments. But now that that individual has done it, I'm just hopeful that perhaps they feel a bit better now and they can, you know, have another conversation again with another friend, as hard as it is, or help other friends to say. Another comment we've got here is, I think that historically people in the community would lay bodies out, etc. It was part of the community conversation and more expected. Oh, that is really interesting, because of course different cultures as well. Yeah, will do things differently, won't they? And there's more of a collective as perhaps an individual. I don't know if you want to be able to add anything about that later. Another comment here is fear of how people will respond. Absolutely. That's why we don't ask it, because are we protecting ourselves? Are we protecting our loved ones?
And I just wonder if Sue, whether I just come back in there, because we talked about hope and giving up hope, but actually I think sometimes we're often just worried about the reaction that we might get. So whether that might be tears, crying, silence, and it's how do we manage that? And I think I think it's about not being afraid of the emotion that might come, and just sort of saying that I'm sorry, I didn't want to make you upset by this, but I think it's really important that we talk about it. Or I see I've stunned you into silence, perhaps we just need to think about it for a few seconds. But it's about going with that a little bit, isn't it? We're all going to react differently in different ways, but it's knowing that from a family member, if you're having these conversations, it's coming from a place of love, isn't it? And care. It's not coming from a place of wanting to upset people in any other way. So I think it's that those elements are important.
That's really helpful, Fiona. So there's no one sentence then that we could all be armed with, that we could go away and paint on our banners right now or write in our diaries,
I think these things are often opportunistic, aren't they? I don't know about you, Sarah. So, there might be an advert on the telly. There's so many adverts on the telly these days for funeral plans or for, life insurance, or at the point where you are buying a house and you've got a mortgage, do we need to make a will, that sort of thing, or you're about to have a new baby. What would actually happen if sadly one of us did die? It's all of those different opportunities in life where I think we should be grabbing those chances to talk about it. Go on, Sarah.
So I was just saying, I think that's why it's far better that we talk about it while we're fit and well, because it's far less stressful talking about it when you haven't got that emotion of actually a terminal illness with you. So like you did, Sue, you had a glass of wine in the garden and you talked about it. And that is far easier than when you've just been told that you've got, say, weeks, days to live, and then you're trying to have those conversations, not upset anyone, not take away hope. So, this is why we're here today, to say, whilst you're well, talk about it while you're well. No, don't wait for someone to say that you're dying and then talk about it.
That's really helpful, because, yes, you're right. Those co-op, although there are other funeral plans, I hasten to add, they are on television all the time, or perhaps even on radio or in a magazine, and that could be an opener. Yes, and to start with, it's going to feel uncomfortable, isn't it? It's going to feel really difficult. But perhaps the next time we go back to that subject with that individual, because now I need to know more about my husband. Now I need to know a bit more about his wishes. And again, I'm just going to keep telling myself that asking him about it isn't going to bring about his premature demise. That's right. Not until I've checked his life insurance policy first, anyway. But, not to be scared. There's another one here. Lots of people choose to die in hospital, especially the closer to death they are. A very small percentage get to die in a hospice. So that's a comment. I mean, is that your experience, both of you?
I mean, sadly, Sue, that is true. And that's down to the number of beds we have for the whole county. So
tell us a bit more about that, Sarah.
So Fiona, how many beds do we have? So at Cransley, we've got 2 hospices in the county, and we're very lucky to have 2. So we've got Cransley Hospice in the north of the county, and that has
9 beds, and Cynthia Spencer Hospice in Northampton has 16 beds. So obviously the hospice beds are quite they're quite pressured, to be fair, and those hospice beds are there not only for people who are dying and choose to die in a hospice. Hospices now are what we call specialist palliative care units. So they are units where we will move people to, for example, if they've got very challenging symptoms towards the end of life, difficult pain, nausea, vomiting, very psychologically distressed, and therefore they need more support in a specialist environment. Hospices are no longer places where people can go for many, many weeks just to be cared for. Yes, some people do choose to die at the hospice, and it sounds very difficult because obviously we're managing beds, but we often try and leave it until we think the person's in the last few days of their life before we'd move to the hospice, where we'd care for them, because sadly, due to the pressure on the beds, then we would have to think about where else could this person be cared for if they didn't need to be in the hospice. So it's a very difficult area, it's a very emotive area, but we have to make sure that the right people come into the hospice beds, and therefore if things can't be managed at home, then hospital is the next place. And to be fair, as Sarah was saying, hospital is often the right place as well. Because people may well be requiring some form of medical treatment up until the point that they're dying, and that may be the right thing to do for that individual, and be surrounded by care 24 hours a day as well. So everybody's different, and often the circumstances dictate what might happen towards the end. So again, like Sarah was saying, we might have this wish that we want to be at home, but then something may happen that makes us think, no, actually, somewhere else is the better place now. And I think you almost have to go with the flow a little bit with it.
Okay, that's really interesting. I'd like to pick up on that in a moment, but I just want to carry on through these comments. So we've got another comment there where one of our guests has known a lot of people wanting to die at home, which is the opposite to the hospital one, in their comfortable surroundings and surrounded by family. So again, I mean, that's that sounds to me very gentle, but perhaps not gentle, because it's never gentle losing a loved one, but yeah, I'm on that one. I think I would prefer to be at home.
I think we have
If I have
to
choice.
bear in mind we work in a specialist palliative care team. So when we get involved in patients, it's often because there might be something a little more challenging around the situation. Obviously, thousands of people die, and dying is an entirely normal process. And for many people, dying will be an entirely gentle, natural process that could well be facilitated at someone's home, or where someone might already be in a nursing home or a care home, for example. So I think often when the sort of specialist palliative care teams become involved, it's because there's something a bit more complicated going on as well. And that might be why somebody might end up needing to be in hospital or in a hospice. So I think it's such a broad area, isn't it? And so I think we're all going to have different experiences of different situations.
That's great. I've got one comment here, which is we have some end-of-life beds at Daintree Hospital in Daventry as well, which one of our guests has helpfully put in the system.
You're absolutely right, Jan. Yes, so we do have some GP-led beds in Daintree as well, that do have some specialist palliative care input into. So yeah, not to forget about those. Thanks.
And then one of our governors is on Rashmi Shah. Rashmi had your hand up. Rashmi, do you want to say something?
Yeah, it was just I just wanted to say that, having a wish, that you can make a wish and experience because of all the in-depth, arrangements, and, sometimes you can't, and it takes too much to organize. And I think perhaps, I don't know, how do you go about to make easier, especially because this dying sometimes comes so quickly, and to communicate, communication sometimes an issue, and somebody's helping. I think it's would be really helpful, that there is a easy sort of communication, somebody who, just hold the fork, basically.
Mhm.
You
I
know,
think
so
we would do everything we possibly could to carry out somebody's wishes, Rashmi, especially if you're talking about they wanted to go home. But obviously we have to make sure that they're safe. And obviously we have to make sure that the family around them are able to look after them as well. And also if they're needing regular medication in a way that we can't provide at home, again, that we would be looking elsewhere. So whatever their wishes are, and again, great to know what a person's wishes are. We will always do our best to carry out those wishes, but like I said, we just have to make sure it's safe for people.
I think it's not just going home. This was more like even if you get in a care home and getting all that to care home where you can get all the nursing service, but it's often the cultural aspect is such an issue, and getting care and then having that sort of negotiation within the once in the hospital. And I think this is one of the things that within the Black and Asian community experience, it's not always so nicer way in terms of getting an understanding and putting things in place, knowing that even where you're putting this person is going to be safe. Of course, the safety is always got to come first, but having considered that, then it is still becomes quite difficult to people and everybody coming together and putting. So I think one of those things that if we can have that link forged, and somebody especially with the people like cultural differences, that would be really one of the things that does lack, sort of thing.
I think you're absolutely right. I think it's important for us not to make assumptions about anybody. So just because we've got the information of someone's ethnicity or someone's religious beliefs, it doesn't mean to say what our perception of that is the right way to go. So I think it's much more important to actually try and address what the individual's wishes are and what's important to them, and what does this mean to them as an individual, and how does that affect them. And I think you're absolutely right. I think there's a long way to go to being much more inclusive with these things, but I think that we're starting that process, and I think it is about, again, the public and family members being open about this is what's important to mum, and just telling us and educating us as well as healthcare professionals, because a lot of this isn't just about healthcare, it's about life and society, and we've all got different experiences. So I think it's important to have those open conversations.
Thank you.
Thank you, Rashmi. We've got some more comments here, which is really livening up, which is great. And then we've got some more hands up, which I'll come to in a moment. So if someone really wants to die at home, but the medical team think they are too ill to go home, surely if they are going to die anyway, their wishes should be carried out. That's one comment. And on the same line, another guest has said, I agree. This is happening with my friend right now, but I wonder if the professionals think she would not be cared for properly if discharged to home. So I know we're all talking about conceptual ideas, aren't we, and good practice, because this is each individual case will be very individual. But I don't know if Fiona or Sarah, you've got any comment on those.
We do, like I said, we will always try to carry out somebody's wishes. And if we do have someone who we think is imminently dying, and we think maybe going home isn't the best option, we will have that discussion with them. Now, obviously, if they've got the capacity that they still want to go, and we have explained to them that maybe, and I'll be quite blunt here, that they might die in the ambulance on the way home, that is still their choice, and we will carry it out. So it's about, again, us having that conversation, making sure that the patient and the family have all the facts of what might happen. If they still want to go ahead with that discharge, we will do it, as long as they are as safe as possible. And we do, don't we, Fiona? And people do, they get home for maybe a couple of hours and then they die. And, to us, that is that is somebody that we've achieved their wishes, even if it is just for a short time. We, like I say, we will do our utmost to get them to where they want to be.
I suppose my advice for anybody that might find themselves in that situation is that it's about just asking the medical team, what is it that you're worried about, you know, so and so going home, because actually there might be a very technical or, you know, practical reason as to why they feel this can't be done. One that's springing to mind at the moment is sort of oxygen requirements, for example, and things like that. So there might be very specific things that cannot be done in someone's home, and it might be just that open conversation that enables everyone to understand this is where we're at and come to. But I think we'd encourage members, you know, loved ones, etc., just to question and ask those questions. Because that will open up a conversation, because if you don't understand that, then we haven't communicated that effectively.
So and this is along the train of discussions coming up here. So in my complete and utter ignorance, if I was admitted to hospital and then it looks as if it's, you know, it's going to happen because of whatever reason. I suppose there's people die at different points, don't they? You know, I mean, I'm riding a motorbike, touch wood, hope it's not going to happen, but you know, or falling off my horse. But I'm also a woman of a certain age, so I might have a massive heart attack. My heart attack might present differently to a male. So, you know, the symptoms might look different. So I suppose I'm not in a bed where the medics have said to my family or to me, there's not any more we can do. I mean, what I guess I'm struggling with is to try and perhaps understand how it works at KGH, but then there's no one way that it works at KGH, is there, because of different people? But help me out here.
I think, so what you're saying is about there's all different types of deaths or dying. Like you say, if someone's coming into A&E in a car accident and they're dying, that's very different to probably the patients that Fiona and I see more with like a terminal illness. But again, that stresses the importance even more about a sudden death, about us talking about what we want previous to that happening. So again, whilst we're fit and well, not on a motorbike, not on a horse, what are your wishes and preferences? So if somebody does have a catastrophic accident, again, the family know what that patient wants, and again, that family can then communicate that with the medical professionals and the nurses in A&E, and we can do it as much as we possibly can for that person.
So there needs to be a nationwide campaign, sorry Fiona, doesn't there? You know, we're all learning about sort of check our energy bills and shop around for the best bank deals, shop around for, but we're not being told how to tackle this really difficult conversation.
I still say that school leavers should be talked about advanced care plan. We don't know what's round the corner.
So what's an advanced care plan, Sarah?
So an advanced care plan is a tool that you can Google it. We do have a Northamptonshire advanced care plan. I don't know if you can see that, but I can put it onto the website.
Yes, please.
We also have it in an easy read version, and it's such a good booklet. It just takes you step by step about writing down your advanced statement of your wishes and preferences, what you want in your will, what you want in your funeral, or even down to where do you want your boots points to go to, because we're of a digital age now, and phones, obviously, if you've got a fingerprint phone, how's your family going to tackle that? It's talking about power of attorney. So they come in all different shapes and sizes, but if you just Googled advanced care plan, and again, it's another great way to have that conversation. And some people might never want to talk about it. And again, like Fiona said, we're not here to make people talk about it, but actually give somebody maybe a booklet that they can fill in. And as long as they tell their family where it is, again, it's another way that we can record what we want when we're faced either with a terminal or terminally, when we lose that capacity to have that conversation. So many tools out there, and again, starts a conversation.
That's great. So advanced care planning. So I'll make sure I include that in the email that I emailed to everybody after this event, just to let them know about it. We've got some hands up, and before I go to those, just got a couple of more comments on the chat box. One guest has said, I've supported people who've only lived for a few hours once they are home. On each occasion, it was the right thing to do, but not always viewed by primary care colleagues as the right thing to do. Yeah, because I guess colleagues, we might work in the NHS, but we won't necessarily all have the same view.
Yeah.
Um,
I think
any comments there, Sarah?
There's
or Fiona?
people who are so desperate to get home, and even if it's just to be at home for an hour, to have their dog on the bed, then who are we to say that that's not right?
Yeah, dog or horse.
Horse, whatever.
Horse.
Whatever takes your fancy, exactly.
Yeah, or the bills. And then what if the dying person tries to tell their family they are dying, but the family are not accepting or too scared to accept it? How do you talk to the family? Oh yeah, that's a difficult one.
It is a difficult one, and also vice versa, Sue, when the dying patient doesn't want their family to know, and actually when it's a conversation Fiona and I have all the time, and actually when you actually sit down with those people and ask why, 9 times out of 10 it's because they don't want to upset each other. And actually when we start explaining about actually withholding information that might actually cause more upset, we usually get a really good resolution. But it is, again, it's just sitting down and having those conversations. People are scared, and we just need to help with that fear, and just say it's okay to talk about it. And if the patient doesn't want their family to know, we do have to uphold that request. We can't talk about anything that the patient doesn't want us to talk about. But 9 times out of 10, it's pure fear. They don't want to upset each other, and actually just having a good conversation with them all, it works.
Great, thank you, very helpful. Right, we've got 2 hands up, so I'm going to take the first hand, which is Richard May. Ooh, the manager of the department I work in. So I'm touching my forelock here in respect. Richard, do you have a question?
Thank you, Sue. No need for any touching of forelocks or anything else. I suppose I'm sort of going back to your original question about why we don't talk about this, and I think we've begun to answer it in some of the things you were saying. So this is kind of comments rather than questions, but hopefully stimulate some discussion. I think partly is about the kind of, you mentioned society, and is really pleased to hear you saying about, you know, even people at school age having, I think, advanced care plans to begin to think about these kind of conversations. And I was thinking, what's the time in our lives probably when we reach some kind of maturity and maybe get married? When do we think about the end of life? Well, we'll make a will, so that's the obvious one there, where we're thinking maybe as a piece of paper about where it's going to. But in all of this, do we think of the kind of, I don't know, if you like, the softer but no less important stuff about almost the nature of, it's getting a bit philosophical here, but the kind of nature of life and death, and kind of, and about beginning to have those conversations about grief, etc. And is the kind of support for those conversations happening there? And I think if we could, as a society, and I appreciate your influence may be limited within the hospital, if we could make some progress there, then it would perhaps take away some of the fear, the anxiety, and maybe also some of the stigma around death, if I can call it that.
Mm-hmm.
My other point was again around the language of death, and we're calling it today dying matters, you know, dying, death, and die, and these are kind of blunt and harsh words, and I guess everybody's got different cultural and religious beliefs, and we all respect those, but we quite often talk about someone passing or passing away, and it's maybe because and again, I respect everybody's right to use whatever phrase they use, but is there something societal there that we think actually it's something detached, it's something out there, it's something that unworldly, something that we can't engage with, so we won't engage with. If we start even something as simple as using death, dying, can that help to break down some of these barriers and challenge some of these taboos?
Definitely. Richard, you hit such a point for me and Fiona. Euphemisms around death and dying. There's so many. We do an awful lot of teaching across the hospital. And one of the things we do is we write lists of all the euphemisms we use for somebody who's dying or died. And actually, then we ask people like about times, you know, if somebody's very poorly, how long do you think they've got to live? If somebody is deemed palliative, how long do you think they've got to live? And everyone will come up with a different conversation, a different thought. But if you say the word dying, most people, 99.9% of everyone will say, yeah, they're literally in the last hours, days of life. And using that word dying, we know, everyone knows where they're at. You know, professionals, families. I've sat down with a family and the doctor was doing a great job explaining what was going on, but didn't use the word dying. And actually the family didn't get it. The moment we used the word dying, they totally got where they were at, and then we could crack on then with carrying out people's wishes and preferences. So it's so important, as hard as it is to use those words. And I have to say, professionals find it really hard to write those words in notes, dying. Actually, it clears up a lot of mystery, a lot of confusion about where somebody is. I don't know if you've got anything else to say there, Fiona, on that.
I think the whole euphemism thing is fascinating. I think it was Marie Curie that ran a campaign, I think, again, just to get us all talking about it a few years ago, of the hundreds of different euphemisms that are out there at the moment, that how people might talk about it. And, you know, things like kick the bucket or pushing up the daisies. Everybody's got a different euphemism for it. But I think as healthcare professionals, as Sarah was saying, it is important that we use the words that everybody understands, just to make sure that you know, we are all talking about the same thing. But again, words only become difficult to say if we're not saying them in everyday society. So, you know, we use the word birth, pregnant, everything else in everyday society, and we don't find those difficult words to use. So we shouldn't find death, dying difficult to use. And the more we do it, and to be fair, I teach this with our doctors, practice saying it, and you will find and learn and gain confidence that the ground doesn't swallow you up once you've used those words. It's okay. And the more that we use it, the more that everyone's going to feel comfortable with using it. So not to shy away from it, really. So no, thank you, Richard. That was really a really important point.
Lovely, thank you. Moving swiftly on, one of our other governors, Jane Smith, has got a hand up. So Jane, would you like to ask Fiona or Sarah your question?
Firstly, hi, good afternoon. First, I'd like to comment on Richard May. He's absolutely right. This passed away and things like that. You really have to be blunt about it to accept it. I got married in 2009 to a lovely man. In 2011, he had a massive cardiac arrest. And thanks to Kettering General Hospital, they saved his life. And I remember the chap, because he'd been put into an induced coma. And I remember the chap coming along and saying to me, we're going to try and wake your husband up tomorrow. And I could almost hear what he was trying to say. I says, it's okay. Don't force him to stay alive. Do what's best for him. And if it's best to let him go, yes, you can take his organs, because he was a transplant coordinator. And sadly, my husband came out of hospital, but he did have heart failure. And as soon as he came out of hospital, he checked that my national insurance contributions were up to date, so that I didn't have to go back to work and I'd have enough for a full state pension. He changed his password on his keypad on his computer to Lazarus. And he wrote a big long letter to me in the drawer. And he says, things to do in case I don't wake up in the morning. And he just wanted music from our wedding at his funeral. And when he did die in 2020, unfortunately of COVID, very suddenly, I found the CD that had 4 pieces of music from our wedding, which I used in that order at our funeral. And all through those 9 years that we had together, we did laugh and joke about it, and he'd buy new clothes and he'd say, these would last me out and things like that. We knew what was coming. We didn't realize it was coming when it did, obviously, but it's so important to discuss things and to have it in plan, because it didn't take away him dying suddenly like he did. It didn't make that any easier, but dealing with the aftermath, it helps. Thank you.
Thank you, Jane. Thank you for sharing that. It's really, really difficult, but yeah, I think you've given us all some lessons there. Rashmi, you've got your hand up.
Yeah, I just again comment with what Richard said. I think what we said, using the word death, and I just wondered you can still use the whether in a positive way, like life matters within that you can bring in, because I had experienced my mom who just went in a hospital late afternoon, and in the evening I got a phone call from DNA sort of thing, and I had to make that decision, and it came so suddenly. So I think it's and dying, it's quite when you are so connected and hard to take. But I think it is talked without. You can still get around those sort of way to inform people. Well, perhaps you could use a like, because it's all about life matters, and within life matters we can bring in a softer touch rather than really hard hitting words. Thank you.
Thank you, Rashmi. Really good points. Have we got anyone else wanting to put their hand up or put something in the chat or have a question? And we'll give you a minute to think about that. So this is one for both of you, Fiona and Sarah. So I know we got this conversation about running this event because, Sarah, you were running some training for staff at KGH, weren't you? As healthcare professionals, am I going to assume that really dying and death, kicking the bucket, pushing up the daisies, rather like pushing up the daisies actually, isn't really talked about? It's probably not on the curriculum because there's too many other things to learn about. Is that part of it?
I think it is talked about. I think it is talked about in nursing school and medical school, but it's when they have to carry out those conversations. We can do all the practice in the classroom, but actually it's about giving our staff confidence to do it in the real life situation. We do an awful lot of education. Every bit of education we do normally has a communication element about how to break bad news, answering those difficult questions. So we really are trying to empower our staff. And like I said earlier, some people just do not find it easy. They're so fearful of saying the wrong thing, exactly like we're all saying as public people, of saying the wrong thing and upsetting someone. So it's about us giving them the confidence to have those conversations. And I'm going to be honest here, we do make mistakes. I've made many a mistake in my past with different families and patients. We can't get it right every time, but as long as we try and have these honest conversations with the families and the patients. Yeah,
that's great. Thank you. Jane Chambers, you've got your hand up.
Thank you. You haven't taken the words out of my mouth on this one. I was going to talk about advanced care plans and the best time to start those a bit earlier, but having lost a parent who died beautifully and pain-free at Cransley Hospice, I can recall having a conversation with some Macmillan nurses when Mum had first been diagnosed with cancer, and it was an aggressive cancer because it was a cancer of unknown primary with about 5 different metastatic sites. And I tried to have an open and honest conversation with them about, this is 23 years ago, so it's not new, about, okay, how long are we looking? Have I got her until Christmas? Have I got her till the new year? Have I got her until my daughter's 7th birthday? And I was quite taken aback by the comment that I got from the Macmillan nurses at the time. So has the approach changed where we're now able to have more of those adult conversations, knowing that when you've a family member's got a terminal diagnosis, that we can really sit and have those adult conversations. Because even to this day, I don't know whether I did the right thing for her or not, you know, and being told we can't tell you because how long's a piece of string, at that time, it didn't sit particularly well with me. And 23 years on, I still remember that conversation. But as I said, Cransley Hospice were absolutely fantastic. So I guess what I'm saying is that when somebody's open to have a conversation about the death of a loved one, that as professionals, I think there's a courtesy for that conversation to be as open and as brave back.
I absolutely agree. I think what's sometimes difficult is sometimes we don't know, and sometimes we don't always have the answer. So I think when we are educating staff about how to have these conversations, we have to sort of bring in some of the science and what do we understand about the illness process or the situation that's going on there. What do we know medically? There's lots of research out there that doctors and nurses, when it comes to what we call prognostication, so the estimating how long someone's got to live, actually, because it's somewhere falls between a science and an art a little bit, it makes us not very good at it. Yeah. And sometimes it makes us as healthcare professionals, again, because we don't want to upset people, we tend to overestimate sometimes as well, because again, we want to be kind and not upset. And again, when we have those conversations, we're very mindful that for some people, if we give very specific times and they live longer than that time, they almost sometimes feel like they're living on borrowed time. And that can actually be quite distressing for some people. It can be great for others. So when we often talk about prognostication, we often talk about it in quite broad terms. So it might be, if it's very clear to us, we think this person might be dying in the next sort of hours or days, we all talk in terms of hours or days. If it's longer, then we might talk in terms of somewhere between weeks and months, but I don't know how many months, or it might be months and years, but I don't know how many years. So we talk in very general terms, because actually we know if we say, oh, they've got 2 weeks to live, A, will be wrong. And B, if they die before that or after that, it's very, very difficult for people to plan. And so often it might be, is there anything particularly important that's coming up that you're concerned that you might not reach? For example, an anniversary, the birth of a baby in the family, and that helps to focus the conversations a little bit. Often it depends on particular times of year, and this is very cultural as well, but Christmas, prognostication around Christmas is always very, very difficult. What we often say is, we don't know if Christmas is an important time, bring it forward. You can always have it twice. And things like that, or but I think it's important to have those prognostication conversations because it helps people be realistic. So it might be that they know they want to go on a big family holiday to Disney in 3 months' time. Well, that person is no way ever going to be well enough for that. So therefore, it's about managing and modifying those expectations. So still they have lovely memories made, but it might just be based on actually what the person's able to do. So there's a huge amount in that question, Jane, and I feel I've gone off a little bit, but
no, that's perfect, because still working in the hospital, we do hear now people talk about days to weeks, weeks to months, months to a year, which is really, really helpful. And we did hit certain milestones. We hit Christmas, we hit New Year, we hit my daughter's 7th birthday, we had our party in Cransley, and we were able to bring Mother's Day forward. So that they were the important things that me as a daughter needed to be able to do for my mum. So it is really important that we're allowed to make the decisions about certain anniversaries and whether to bring them forward or specific dates. So I'm pleased that we're talking in that way, because it does help a lot of people.
And again, Jane, it's about us telling each other what's important to us. So last year we had a patient whose Christmas was so important to them. So we got them home in time for them to see their Christmas tree. So if we don't know, we can't plan. And so again, and we'll only know what that person wants if we talk about it.
Which is why I think when we were talking, we were doing training about the advanced care planning, isn't it? And for me, I'm a big advocate of, even if you don't fill it out for your family because you're still worried, fill it out for yourself, so that when that time comes, because we're all going to get there, aren't we? We're all going to die, and we have to remember that. And I keep saying to my daughter, this is the death that I want. These are the decisions that I'm making whilst I'm of sound mind for you, so that you don't have to make them. Because I think that's sometimes one of the legacies, isn't it, of not having something written down or not articulating it, is that a family member then has to guess or make it the best guess of what we do for our loved ones when it comes to their death. It's been really fascinating. Thank you.
Thank you, Jane. Just wrapping up, we've got a comment here. One of our guests, prevention and domestic abuse awareness. And the more you say those dreaded words, the easier it becomes. Yeah, so true. Another comment, it's important the conversations need to be available earlier in the patient's pathway.
Definitely. Definitely. So I'm a big advocate for this. And I think, again, you know, when people are first diagnosed, say with dementia, early dementia, that's the time we should be having those conversations, not when they've lost their capacity to make decisions. Again, anybody I feel with sort of a life-threatening illness, that advanced care plan should be talked about at that initial diagnosis. It's so important.
So as loved ones, are we able to trigger that a bit?
Definitely, definitely, and that's what comes back to where, you know, this whole conversation started. If we can empower the public that if they are sat in an outpatient's appointment, that they've got the confidence to ask that difficult question to that consultant, that doctor, that nurse who's sitting with them. So again, it's about us being confident in asking those questions.
Great. And then we've got one more. Are there any advanced care plan booklets available in hospitals and doctors? So you've mentioned one, Sarah, the Northamptonshire Advanced Care Planning document.
Yep.
So if you can send me a link to that.
Send you a link to that one, and it also comes in an easy read version as well. So yeah, I'll send you a link for that soon, no problem at all.
Thank you, and then I will share that. And then I think, unless anyone's got anything finally, I think we'll wrap up. But I just want to share. One of our guests said, "My mum died at 7:30 on the morning of William and Catherine's wedding. She was a royalist, and our guest was so cross with her. But she would have seen or perhaps heard about the pre-planning of the wedding, because the media would have been full of it. So." Yeah, well, I think I'm going to draw this to a close unless anyone's got anything final that want to add, or Fiona or Sarah, is anything you'd like to add before I close this?
I think I'd just like to thank people for being brave and putting their questions in the chat and raising their hands and demonstrating that actually, yes, we can do it, can't we? We can have a conversation about it because we've done it this afternoon.
Yeah.
So thank you.
Yeah.
Thank you, Fiona.
Thanks ever so much for this opportunity. It's like I say, it's so important to us, and we so see the difference when we're talking to families. You know, when they've spoken about it with their loved ones, it makes a massive difference. So thank you.
Right, great, thank you. Well, thank you to our guests, and we all know we've got to keep talking. Anyway, you take care, everybody. Thank you. Bye-bye.